So this was a study that combined Nivolumab plus trans-arterial Tirapazamine embolization, so we're going to call it TATE, in patients with very advanced HCC that had failed at least one line of immunotherapy. So right now, patients who have failed like one line of immunotherapy, there's no standard of care. And so this is the population we were targeting. What we do is we start them off on Nivolumab. A week after that, they undergo TPZ embolization. Tirapazamine, just for a little bit of background, is a hypoxia-activated agent, which means when it's in a cell that's hypoxic, it turns into a free radical that attacks the cell and causes necrosis. And so what we do is we get into this arteries supplying the tumors, we infuse the TPZ, and then we embolize those vessels. One, the embolization shuts down the blood flow, which decreases the oxygen and places those cells into a state of deep hypoxia, which activates the TPZ, and also enables the TPC not to be washed out from the tumor. So once there's necrosis of the tumors, there's release of antigens and activation of DAMP, and so that activates the immune system that's already been primed by the Nivolumab. We've seen very encouraging results. This is still a small study. We have 18 evaluable patients, but we've noted a 55% M-resist response rate. The disease control rate by resist is 77%. And 5 of the patients had extrahepatic disease. 3 of those had significant shrinkage of their extrahepatic tumors, and that included adrenal mets, lymph nodes, lung mets, and bone mets. It's significant because local regional therapies by themselves would not induce a systemic response, these patients were on immunotherapy and were progressing, and those lesions were growing, but now the combination of the two is resulting in responses that are very encouraging.